Hello, hello everyone. This is Dr. Uma. I'll be presenting slide notes from Dr. Hamed Iron about bilirubin metabolism. Okay, so we want to check on the jaundice and then bilirubin metabolism. Okay, so bilirubin metabolism. Now, what is jaundice? It's a normal thing you will always hear whether you're rotating or maybe you're practicing as a student as well. You know what we call the yellow discoloration of skin, mucous membrane. Both adults and the newborn, I mean the children, they can present with the yellow discoloration of the skin and mucous membrane. So it's not normally the skin alone, can even be the nails, okay? So and the mucous membrane commonly, and also the sclera, the part of the eye that we call a sclera. Now this is always due to accumulation of bilirubin. And clinically, it's apparently when we check for bilirubin levels and they reach 2 to 3 milligram per deciliter, that is equivalent to 34 to 51 millimoles per liter. The normal range is supposed to be zero point 0.3 to around 1 point something. It's not supposed to reach 2. So any clinical apparent when bilirubin reaches the level of 2 to 3, then that is jaundice is indicative of what we call the hyperbilirubinemia, okay? Now, it may be the earliest signs of liver dysfunction, so it always needs an urgent evaluation. Because generally, why liver? Because liver is where we normally get the bilirubin from given metabolism. Actually, the breakdown of the part of red blood cells give us the bilirubin. So there's that cascade. That is what you want to check majorly, and then see jaundice. So breakdown of mature red blood cells in the system, okay, in the rest. So what happens is the red blood cells we always expect them. They are servers, they transport oxygen. I mean, they also help in gaseous exchanges. I mean, we have several things apart from that as well, which are actually compounded to RBCs, or what you call the red blood cells. But then when they take 120 days in the system, they're supposed to be mature enough to break down so that the bone marrow and the spleen in babies can now produce new red blood cells. So those pluripotent stem cells can now come into play. So 15% from the catabolism of other heme-containing proteins, and then the remaining 85% comes from the breakdown of RBC. That is bilirubin. Bilirubin, the 85% comes from the RBC breakdown, and the 15% comes from the, I mean, catabolism of other heme-containing proteins like myoglobin, cytochromes, etc. So when you have hemoglobin, which is a part of the red blood cells, this hemoglobin, when it breaks down, it will give us heme and globin. Heme is an iron containing moiety plus bilirubin. We get that. So either bilirubin can be there, when you break it down, it can be there in form of unconjugated one, or water insoluble, or bound to albumin, or then transported to the liver. Okay. So the hepatic steps necessary for bilirubin clearance from the plasma, which if fails, we have now accumulation of bilirubin in the system. So first, uptake. The bilirubin is supposed to be uptaken, supposed to be absorbed, supposed to be uptaken by the hepatocyte, the liver cells, and then to the bile duct. Or they can be conjugated into soluble and then be excreted. Or they can as well be secreted, okay? So those ones help in clearance, but if this one fails, then you get to have jaundice. Bilirubin is taken up by hepatocytes by a carrier, or what we call the ligandin. And then inside the hepatocytes, the way I told you, we have hepatocyte uptake of the bilirubin, clearance of bilirubin, and then the other one which I told you is the conjugation. Okay. So inside the hepatocyte, bilirubin undergoes conjugation with the glucuronic acid, or what we call the uridine glucuronic acid, the UDPGA, just in form, in abbreviated form. So once it undergoes conjugation, it forms conjugated bilirubin and UDP, that is urinidine diglucuronidase, whatever. So enzyme responsible are uridine diphosphate the diphosphate glucuronidase transferase, or UGT1, That is the one which helps over through the conjugation process of the bilirubin. And then this enzyme, now after the bilirubin is conjugated, called now conjugated bilirubin. And the one which is not conjugated, the one which has not done the process of conjugation, that's unconjugated bilirubin. The bilirubin must be conjugated for it to be excreted. So conjugated bilirubin are excreted actively from hepatocyte into the bile using acid ATP carrier, where they help in the formation of the bile salt. Okay, so this is the thing. So that is now uptake. It's now done. Bilirubin, the one which was there, has been uptaken, and then it's done. So we have unconjugated one through the ligandin. We get the unconjugated bilirubin plus UDP, which is actually the hormone glucuronosyl transferase. It forms conjugated bilirubin plus UDP, and ATP is involved to form the conjugation, the conjugated bilirubin. Okay. So bilirubin conjugates excretes in bile as what we call diglucuronides. Diglucuronides, what actually 80%. Then we have monogluco, or what we say monogluc, 15%. And the other bilirubin conjugates. So the glucose and xylose so come to be. So when they're conjugated, they're excreted in the form of one diglucuronides, that is 80% of the conjugates excreted, and then the monogluc covers 15%, then the rest, which is around 5%, is just glucose and xylose. So the bilirubin conjugates excrete against a concentration gradient via the ATP dependent canaliculi multispecific garnic anion transporter. So they go against the gradients because they are excreted via active transport, which utilizes the adenosine triphosphate, the ATP. So that all is just a carrier. It's called canaliculi multispecific garnic anion transport, which helps in. So when you have genetic mutation that alter these transporters, okay, or these carriers, they cause disease such as, cystic fibrosis, hyperinsulinemia, multi-drug resistance, and Durbin-Johnson syndrome. These typical diseases come as a result of genetic mutation. So when you give phenobab to a patient who are suspected of this CSF, multi-drug resistance, what normally does is that it increases the activity, or what we call the steroid-reduced activity. Okay, and in such a case, it helps over to relieve all that. So if somebody is having jaundice related to cystic fibrosis, or maybe hyperinsulinemia or multi-drug resistance, then the indicative of phenobab, which increase the activity, steroid reduced activity as well. So unconjugated bilirubin, the one which is not conjugated, they bound to albumin. Remember, albumin is in the blood. So then the ones which still unbound, like some of the part of the unconjugated will bound to albumin, and then you have the unbound unconjugated bilirubin. These ones they're very dangerous. The free ones which are roaming around, they can cross the BBB. BBB is what we call the blood-brain barriers. We have specific organs which actually have blood-brain barriers, and these ones protect the regions, those organs from the the dangerous there, or maybe some substance like drugs from entering those areas which are not supposed they are not supposed to enter. Like testicles have got blood-brain barriers. Okay, the brain has got blood-brain barriers. So BBB helps. So this free and conjugated bilirubin can cross when they cross, what can give us complication like kernicterus. Kernicterus can make somebody to be mad. Actually, it's a brain condition, which is an emergency condition. And then the conjugated bilirubin will appear in urine. So when you do urine analysis, that is the dipstick or any, you can quantify some presence of bilirubin. So we measure them by what we call Van Denberg reaction or Van Denberg reaction. We have direct bilirubin. You know that when you're doing your lab works, when you're sending a blood sample for billies, we call them billies. You have the direct one and indirect one. Okay, so the direct one is what we call the conjugated, then the indirect one is what we call the unconjugated bilirubin. So hyperbilirubinemia may form a primary abnormality in bilirubin metabolism in the absence of further liver disease. We just call it hyperbilirubinemia. So hyperbilirubinemia from a primary abnormality in bilirubin directly, that is from metabolism, okay, without any disease called that. That is just hyperbilirubinemia. So we don't bring in jaundice, we don't bring in all those other names, okay? Yeah, we just call it hyperbilirubinemia when it comes from bilirubin metabolism. So hyperbilirubinemia causes conditions such as Gilbert's disease, Crigel-Najjar syndrome type 1 and 2, and then the conjugated hyperbilirubinemia causes the Bean-Johnson and Rotor syndrome. Okay, so the common ones are the latter, that is the Dubin-Johnson, the Rotor syndrome. Now, I want to check a bit of this. So, causes of jaundice, we know bilirubin, conjugated or unconjugated, can cause jaundice. So, let's see about unconjugated bilirubin, which is most. So, this unconjugated bilirubin, we had already discussed them. They are hardly going to be excreted, so they will be either bounded to the albumin or free, and then they can even cross. So, mostly unconjugated bilirubin is caused by one during the production of bilirubin, that is metabolism process, or hemolysis. Hemolysis is when now the red blood cells are overly being broken down, even mature or immature, the cells are broken down. And if we have increased hemolysis, there will be more bilirubin that cannot take part in bilirubin metabolism and therefore give us unconjugated bilirubin. Reduce hepatic removal. When the hepatic cell, the liver cell cannot remove all the available bilirubin, then others will be left unconjugated. Okay. Then what causes conjugated bilirubin, which is actually about 20% of the total or more than 20% of the total? One, conjugated bilirubin can be under-excreted, so they still remain in the blood. Hepatocyte damage can also be a reason. And then biliary tract damage, because that is the route that they follow, can also be a reason. So increased production of unconjugated so in case of unconjugated hyperbilirubinemia, we talk about what can cause it. I told you we have increased production, such as hemolytic disorders, so the blood just broken down anyhow. Can be hereditary hemolytic disorders or acquired. Blood group incompatibility is one of them. Membrane defects, enzyme defects, hemoglobinopathy, uh, HUS, what you call hemangioma. Those are cancer of blood. Okay. So infections, sepsis, polycythemia, those are things that can come about. Then decreased uptake, transporter deficiency, hypoxia, acidosis, hypothyroidism as well. Decreased uptake, the I told you, can be due to transporter deficiency, those abbreviated terms that I mentioned, hypoxia, acidosis, and hypothyroidism. Decreased conjugation process, we talk about neonatal jaundice due to decreased conjugation, inhibition, hereditary Crigers, Najjar, Gilbert diseases, and hepatocellular dysfunction as well can bring about decreased conjugation, which can still give us unconjugated hyperbilirubinemia. Okay, breast milk. This one called the breast milk jaundice. The jaundice which comes uh, uh, when the or to a baby during the breast milk. Okay, and then infection, jaundice, conjugated. This one can be caused by conjugate. This one can result. So these are the list of the causes of conjugated hyperbilirubinemia. So we have infection, extrahepatic disorders, metabolic disorders, and toxins. So when we talk about infection like just bacterial sepsis, viral hepatitis like hepatitis ABC, cytomegalovirus, herpes simplex virus, HIV, TB, and syphilis. When we talk about extrahepatic diseases like biliary atresia, what we call the colorectal cyst, gallstones, and the tumors. Metabolic disorders, such as the one called the lactosemia, lipid goiter disease, tyrosinemia, and others. Okay. And then toxins such as paracetamol and aflatoxin can as well cause conjugated hyperbilirubinemia. Okay, should know that. So Gilbert's disease, these are just assignment I want to leave. Go and check on Gilbert's diseases. Go and check on the diagnosis of Gilbert disease and the treatment of Gilbert disease. Check on Crigler-Najjar syndrome, diagnosis and treatment. Okay, check on Rotor syndrome, which is a familial disorder, chronic elevation of both conjugated and conjugated bilirubin. The total bilirubin from 2 to 7 up to 20 milligram deciliter, that is okay, and 50% conjugated. Deficiency in hepatic GST, that linker, that's a transporter which impair uptake and leakage of conjugated bilirubin. So Rotor syndrome, that is the pathophysiology. So you're gonna check and revise on them, check on Dubin Johnson syndrome and revise on them. And then I want to tell you that thank you, follow us, subscribe to our channel, in YouTube.